Hello everyone. So we are going to look at the doubts of the post-course session after the .com TLH webinar which we conducted on the 17th of March. Yeah. So for those of you who attended, I think you have already seen the video, and those of you who have not attended, we had a massive response of around 500 plus delegates from I think around 27 countries. So the video is still available to watch. I'll share a link along with this particular video. You can still register and watch the video. This will be available up to 16th April 2024, after which we will have to remove the video from the server. So with that, these are the post course doubts which all of you had. I believe most of you have been added to the group now, and so we've got about 500 plus people in the group. So let's start off with the doubts. So the first doubt is if we could have a webinar exclusively for endosuturing basics. Yeah, we can have. In fact, I have some videos on YouTube which I will share, but like I said, endosuturing is something that is to be given or can be covered properly only in a physical event. So we'll try to do that. Then about the certificate you had asked, yes, certificate will be mailed to each and every participant from conference on their own email ID. From where can we buy the Dr. Sangpal's manipulator? So here in Mumbai at least, Dr. Sangpal's manipulator is being manufactured by Kalelkar Surgical, and it is the same design is being manufactured by other companies as well, but this is the original design, though I don't know if they will ship to another within India. Of course there should be no problem, but I don't know if they ship to other countries or not. So maybe I can try to find out if they do that, or give you an alternate number who does. Shearer, mostly I am buying either from PB Surgicals or from KK Surgicals. Both of them have their websites. If you Google, you should be able to find it, and they have good designs, so should not be a problem. Of course, you can also my cautery or my generator is from Allen Medical Systems, and you can also buy. Allen also has their own shearer, so that is maximally compatible with the machine. So if you're going to buy a new machine, then it might make sense to buy the shearer from them itself. Then how to join the WhatsApp group? Yeah, fellowships, yes, fellowships are there, but fellowships are long term. These are 1 month or 3 month events, and at present, because I take only one fellow at a time, we are booked up till the mid of 2025. So but still, if anyone is interested, you can write a message to me. I'll try and tell you where and how you can come in. So yeah, so I don't think these are doubts. The conference team will, yeah, so no, the recordings will only be there for 1 month, after which it will be removed. Coming to your first query, so before I begin with my queries, all of your names are going to be saved with different things. My OT assistant has saved them as 1703 and various other things. Some of the names you will also find with the acronym HOT, which means hands-on training. So either you've done some training with me, or you have you've inquired for training. So that's what that means. Do not get any other wrong concepts. So the first one is, I did TLH today after attending your webinar. Uterus was 12 weeks, optical trocar 1 inch below above umbilicus. I had to put myoma screw, created extra port, but that created trouble. Ports were obstructing view. So yeah, when you put your myoma screw, the myoma screw obviously has to go in through the side port. If the myoma screw goes in through the center port, it is going to cause problems. So myoma screw has to be inserted from the assistant side lower port or upper port to be able to give you the best view, and then the instruments will not come in. I think all of these queries have now been tackled, and if all of you are able to access the recordings, etc, etc. And so let's go down here. Pre-course videos, 2 sections, that was answered. Thank you all those who answered these queries on my behalf. So now this is the question: post TLH patient developed urinary incontinence and how to proceed. So this is an important, rather a very important question. If the post TLH patient has developed urinary incontinence, then first I would suggest is, first thing to proceed means you should see your video. And if you are not recording your own videos, then that's a wrong thing, because only this will give you the courage and confidence to understand where you are going wrong. Okay. So first see the video, see if you have been if you have done excessive cauterization. Okay, there is likely to have to be excessive cautery done at mostly at the level of the uterine artery, and this has caused a coagulation injury, and this has caused in the long term, this has caused a fistula. So now first thing to determine is, of course this is a very short this thing, but first thing to determine is whether the patient has actually a fistula or not. So in order to do that what I would suggest is, you will have to first examine the patient in the OPD and see if she actually has any urinary leakage or not, or if it is just vaginal discharge. So that is done. If she actually has urinary leakage, then clinically in the OPD, the only way to find out from where it is coming is to do the 3 swab test. Yeah, and in the 3 swab test, as all of you know, if this is the vaginal fornix and this is the cervix is not there of course now, but this is the vaginal fornix, and 3 swabs are placed. So 1, 2 and 3 large swabs are placed, and the bladder is filled up with methylene blue. So the bladder is I'm sorry about that. So like I said, this is the vaginal vault and this is the opening, and 3 swabs are placed, and the bladder has to be completely filled up with methylene blue dye, because unless the bladder is filled with methylene blue dye, you will not get any regurgitation of dye. So once the bladder is full of methylene blue and you put these 3 large dry swabs inside, swab 1, 2 and 3, you ask the patient to walk for some time. Because of this walking, the urine will come out and it should stain one of these swabs. So what is the diagnosis that you infer from this? If swab number 1 is wet and it is blue, then this is a vesicovaginal fistula. If swab number 1 is wet but it is not blue, okay, that means there is urine coming in, but it is not from the ureter, it is not from the bladder, so that means this is a ureterovaginal fistula. Okay, and if swab number 3 is wet or swab number 2 is wet, then you have to see if there is any fistulous communication at a lower level or not. But essentially what you are checking for is whether you are dealing with a case of VVF or whether you are dealing with a case of ureterovaginal fistula, and you are going to be managing that accordingly. Of course this is just a clinical test, but the other tests that are available are giving the patient oral pyridium. So this is a tablet, pyridium tablet. It stains the urine orange, so you can give it and you can see whether the discharge that is coming out in case of small fistulae, whether this is orange or not. It's not very specific, but you still get some idea. Then of course once all of this is done, the important thing to do is to ask for a CT urogram. This is required because CT urogram will tell you at what level is the defect, whether it is in the ureter or it is in the bladder, and so you can counsel your patients accordingly. Now a very small means very small defect in the bladder, it usually heals spontaneously by prolonged catheterization, but this is very rare, so it has to be literally maybe 1 millimeter, 2 millimeter or 3 millimeter in size for it to heal. Otherwise mostly it will not heal in this way, and patient will have continuous symptoms after the catheter is been removed. So then she has to go for surgery, and it could be a ureteric fistula in which you will see a communication on the CT urogram and at what level the communication is. So you will find out that as well. So once on the CT urogram it has been proved that there is some sort of fistula, then of course you have to repair it. So if you have detected this in the immediate post-operative period, So immediate post-operative period, then it, and you are talking about, and we are talking about a ureteric fistula, then it may be possible to stent the ureter. You're stenting the ureter sometimes and leaving it in maybe for a month or a month and a half. It causes healing of the wound which was there around, and some fibrosis ensues, but it does not narrow down the lumen of the ureter. Okay, it just stays inside, it does not narrow the lumen of the ureter. And sometimes for smaller cases in which the injury is small and the defect is less, it may heal completely as well, so you don't need to do anything more. But if the injury is bigger, or if the urologist feels that no, this is not a case for stenting, then directly you have to go in for the reimplantation of the ureter. Okay, and since your patient, since you said that your patient has developed urinary incontinence, that means that there is a possibility that rather a fistula has definitely formed. So just be sure to check that whether it is SUI or not before you start off with the treatment. Then reconfirm that it is actually urine that you are seeing. Then do a CT urogram, and based on the urogram you will have to counsel the patient as to whether she will require a repeat surgery which is for a VVF, or she may require only stenting if it is a very small ureteric fistula, or she may require reimplantation surgery. The possibility of ureteric reanastomosis surgery seems to be less, because this is already formed a fistula. If you cut the ureter on table and the ureter is cut not very close to the bladder, so if this is the bladder and if you have not cut it very close and there is a good segment which is available on both the sides, then a reanastomosis can be tried, joining the two ends to each other. But usually this will be difficult unless you have dissected out the ureter completely and then it has got cut in the somewhere in the center or higher up in the pelvis. So this is generally the treatment protocol that one would follow for a incontinence patient. So I hope that is clear. Then best laparoscopy book for beginners I will try to send in the group. Frequent pneumo loss in obese patients despite no leak. I think this was very well answered by this one, Dr. Nagesh. So thank you very much. Calibration of the instrument is very important, and also whatever he has said that the instrument loses calibration if you don't switch off the CO2 before switching off the machine. I think that's a very important one. You can get your machine checked. Also, one more point is you try to keep the insufflator above the level of the patient's abdomen or at the level of the patient's abdomen. So if your insufflator starts coming in, so if this is the patient is lying down like this at this level and the insufflator is delivering gas from this level, then sometimes you find that the insufflator faces difficulty, although it should not. Plus all the blood and fluid which is there inside the abdomen can gravitate down the tube into the machine, and then it can spoil the machine. So try to keep the machine at the level of the patient or above the level of the patient, and then this problem might just get solved. Okay, then so then this query that you reverse the operating table. So like I said, we already discussed this in the webinar, but operating table is to be reversed only when you have a table which has got a fulcrum at one end. Okay, so if this is the OT table, this is the table and this is the fulcrum, then what happens is when you give head low, this table is going to go up like this from the fulcrum, and that will raise the patient's height significantly. However, if you already have a table whose fulcrum is right in the center at this location, then even if you give head low position, this will go down, this will go up, but effectively the pelvis will remain at the same level. So turn the table around only if you have an orthopedic kind of table. And you can use pata, means people who are not speaking Hindi or do not understand. Some of them us are from outside India as well, so this means platform. You can use platform. If it was uncomfortable, you can use a larger platform, so it's like almost you are standing on the floor. So you will be but if you're doing both of these things and if you're still having a difficulty, then I don't know what is the issue. Maybe like someone suggested, you can actually send a video of the situation, so we'll get some idea of what is the problem that you are facing. Then We go down. Yes, keep table at lowest height is correct. I created conventional ports for 12 weeks, which was 1 inch above the umbilicus. I found difficulty in my removing congenital along the sigmoid. If you can just share a short video of how things went, then we can have more clarity. Otherwise, I think I already told you. Yeah, these shoes are a good joke, but no, I don't recommend wearing any shoes. How to deal with fogging? I personally use warm saline, because the reason for using warm saline is, yeah, you can use autoclaved water as well, and you can use warm saline. Saline does not damage the scope in any way. Rather, it has to be hot saline so that it gives you a very crystal clear view, especially in cases of HD and in 4K cameras. So the difference after using warm saline is amazing. You can use betadine as well, although someone has said it does not change the field, I mean doesn't change the color, but I find a slight change in color which disturbs me, so I like to use saline instead of betadine. Boiled or autoclaved water is okay, but then boiled water is not entirely sterile, and autoclaved water, yes, but most of our OTs may not have the facility, so you can use whatever you want, but I prefer to use a small 100 ml bottle of saline. I keep it standing in the tea kettle which we use to heat water before making tea, and then as required the OT assistant gets it, I dip it and put it back. Okay. CO2 is a cold gas. This is correct. This is also one important thing. So what you have to do is, because CO2 is a cold gas, your insufflator, when you use your insufflator, I have an insufflator which delivers pre-warmed CO2. Okay. So pre-warmed CO2. So if you're using the stores model, you will see that there are some which are called as endoflator, and there are some models which are called as thermoflator. And in a lot of Indian models also this is there. So the thermoflator, after the first 15 minutes of surgery, starts delivering warm CO2, and then you find that in the first 15 minutes you have issues, but after the first 15-20 minutes, at least I don't have any issues with fogging at all. Can we recognize that we put in the, is it yes, reinsert the trocar, because yes, like Dr. Shalini said, you can't do anything with wrong trocar placement. Large mass uterine, all the ports will go higher. We discussed this in the webinar, Dr. Irwin. We discussed this in the webinar that you have to go higher, because what will happen is, if your target organ is too close, yeah, so if this is the target organ, let's say this is the pelvis, this is the uterus that you are removing, and you put your trocar, so if this is the abdomen like this, yeah, and this is the uterus that you have to remove, and you put your trocar over here at the umbilicus, there is hardly any space left between the two, and then if you cannot get a panoramic view, you will not be able to operate. You have to see both your instruments converging, and for that you have to put the supraumbilical port so that both of your instruments can be seen converging at the level of the supraumbilical port. Then knowledge of anesthesia is good. Yes, you should have knowledge of anesthesia. And the port positions, I think Dr. Shalini has mentioned quite well. Also, we have discussed this in the webinar, so I'll just advise you to go back to the video and see. We've discussed for standard built patient, obese, thin patient, large pathology, everything we've discussed. So I think that's no problem. This is the port placement thing. Like I said, it's this is the exact port placement that I use, at least this one. So you can see over here, these are the two primaries, and these are the two primary ports. I'm sorry about that. So these are the two primary ports. This is the first accessory port. So this is in if this is the anterior superior iliac spine, this is at the junction of 2/3 and 1/3, and you have to remember that this will change. So when you do a few cases, you will understand. Yeah. So if for example, just to give you an example, if the uterus is like this and the round ligament is here, okay, then you cannot put your primary port below the level of the round ligament. Your instruments will go against you. You will be operating looking up towards the abdomen. That's not how you can do surgery. So if your pathology is something like this and your round ligament is like this, then this port will shift over here approximately. Then correspondingly you will have to go 10 centimeters up and 3-4 centimeters inside, so your other port will shift here. So this will be the two ports which you will have, and then obviously the supraumbilical port will go here. So some changes are required depending upon what exactly you are doing. Yeah. So then let's go ahead. In Indonesia, many surgeons insert the primary trocar. It's aesthetic but yeah, I already told this. So when inserting supraumbilical trocar will be decided based on size of pathology, previous surgery, previous laparotomy, previous cesarean section. These are the cases where I would prefer to put supraumbilical, and in patients who have got previous midline vertical scar, then we are directly talking about either a Hassan's entry or a Palmer point entry, or in India now we have the Jain point which is used. So thank you madam for this diagram as well. Then we go to pre-course videos. Pre-course videos are still available. So let's see if you are not able to see the pre-course videos. I doubt that pre-course videos will have been taken out, but let's just give me a minute to scroll down. We will have the link somewhere here. Yeah, so this is the link. I hope you can see it. I'm clicking on this now. So it should take me to conference. We have 536, so I think about 40-50 people enrolled after the thing. And in syllabus I'm able to see all the videos. Yeah, so this is the first one. You can see it opens up quite well. This is playing as well, so it's playing nicely. So just check. I don't know what is the issue at your end, but the pre-course videos are playing quite well from my side at least. Okay, then let us go on to the Google form in which some questions have been posted. So just give me a second to pull out that Google form and then we can discuss. Right, so these are all the responses that we have, and let's see it category wise. So first category is patient selection, TLH versus open. Do you do 2D echo of all patients posted for TLH to assess cardiac status? Now, as a matter of fact, I do. Earlier I was not doing, but we had some complications in between, and now at most of the corporate hospitals where I am attached, they have made it mandatory to do 2D echo for every major laparoscopy that we do. So yes, I do 2D echo for all TLH patients. Sometimes it may not be done at the discretion of the anesthetist, but it's safer. Yeah, so prefer TLH, no problem. Demonstrate indications, it's all there in the video, so you can see. I do VH in descent and all routine up to 12 weeks, all open surgery for gynae onco. This is perfectly fine. Like I said, whoever is able to perform more and more difficult VH is doing the most justice to being a gynecologist. So vaginal route is the best route of surgery. 2 patients, one with multiple 30 weeks and one with single 30, operate the multiple fibroid one by TLH as compared to the single huge fibroid one. No, actually there is no such thing. Like I told in the webinar also, what is important is the uterus free pelvic space. So for example, this is the pelvis and this is your patient 1 and this is patient 2. So one patient has got multiple fibroids and it is 30 weeks, and the second patient has got a single fibroid and is 30 weeks. To me, I don't think it matters too much because it will be the same level of difficulty. What will matter is this space, the uterus free pelvic space, like I discussed. Wherever it is there, good amount of uterus free pelvic space is there, you can do, and where it is not there, it will be difficult. Obviously it will be that if the fibroid enlargement is like this laterally, then this case becomes more difficult as compared to if the fibroid enlargement is like this, because again the same fundamental comes in, that the lateral space is available and my instruments can go in. Here there is no lateral space available, it's blocked from both the sides, and so I cannot do anything. So that would generally be my answer for this. DI is not clinically detectable, so lap is convert. I know that's a common problem. Ideally it should be diagnosed, but it doesn't get diagnosed. But then if nothing else is possible, you can convert to open. Don't be so worried about converting to open. You are not committing a sin. Port placement, do you follow the baseball diamond concept? No, I don't follow the baseball diamond concept because I do ipsilateral suturing. Those who do contralateral can do baseball diamond. This is also discussed extensively in the video. Previously scarred abdomen, VisiPort is better or as the first port entry. Yes, if you have VisiPort, you can use the VisiPort as well. But for personally for previous scarred abdomen, I would like to do palmar point entry because that is safer, or Hassan's technique of open laparoscopy. Supraumbilical, role of suprapubic port, I told you larger size. So for me, beyond anything beyond 12 weeks also I would take a supraumbilical port. In which cases is role for beginners for vault cutting? I told you suprapubic port, what is the thing. Improved after the webinar, thank you very much, that's very nice to hear. We always make primary port entry at the umbilicus for any teaching for anatomy and entry tech. In fact, if you find when you do cases, you find that though it is technically said that umbilical port is better, the supraumbilical port works out to be easier. Okay, so practically when you see the supraumbilical port entry is easier, and that is for the reason that you imagine that this is the umbilicus, this is the abdominal wall, and all of these layers are coming inside and meeting at the abdominal wall. So what they do is they form an umbilical tube. Okay, they form a decussation and they form the umbilical tube, and this umbilical tube is thick. So unless you take an incision and go right through the center of the umbilical tube, that is when you will not face much resistance. But if you take an incision on the side here, or if you put your trocar, so suppose this is the inferior side of the patient and this is the superior side of the patient, if there are people who take an infraumbilical incision and then try to go through like this, you will find a lot of resistance and a lot of difficulty in going in. I hope my point is clear. So for supraumbilical there is nothing like that, it's a very easy entry, but I agree it's not cosmetic. So in very obese and very thin, already told you, tips to enter means it is said that the obese patient is the easiest patient, safest patient to enter but difficult, and the thin patient is the easiest patient to enter but more dangerous. So of course you will have to be careful when you place your ports. Then third one, cornual structures. No problem bleeding after the webinar, but my concept is clear. Thank you. So you can we make rule 432 for round ligament and denote the, say? You can, sir, you can make any rule as whatever you want. The concept you have to remember, then you remember it in your own rule, and when you take the trouble to teach 3 or 4 juniors who are there with you, once you teach them, the concept gets so crystallized in your head that you can teach it to 100 people without problem. In 24 week size gravid uterus, subserosal fundal or broad ligament fibroid, only in DI, no difficulty. So I think cornuals, everyone is quite comfortable. Then let us go ahead. That's about a bladder dissection. We have only ligashore and monopolar, it is difficult. Yes, if you have only ligashore and monopolar, remember that ligashore, one of my issues with using the ligashore is that is one of the advantages of ligashore actually, and that advantage of ligashore is that there is no lateral spread with ligashore or minimal lateral spread, because if this is the two jaws of the ligashore, you find that these jaws are insulated, so current never goes out beyond the level margin of the jaws. But sometimes during bladder dissection, so this, suppose this is the uterus which is being pushed up, yeah, and this is the bladder over here which has been dissected down, and I find that I have got some stray bleeders over here which I want to coagulate, and I take the ligashore and go with it, then I cannot do what we call as a spray or a surface coagulation, which can done very easily with the bipolar, where you just hold the open bipolar and fulgurate it so that the current spreads and stops the slight bleeding. So if you have only ligashore and monopolar, you have to have, without, like I said, without a bipolar grasper, this surgery should not be performed. Everyone has to have a proper bipolar grasper to do this surgery effectively. In cervical fibroid, what precautions to take? There is already 2 or 3 good videos on my YouTube channel. You can see those videos. I have explained everything. Explain lateral bladder pillar dissection. So there is no such thing as a lateral bladder pillar actually. It is just a condensation of fascia. So if this is the uterus which is ahead, and this is the bladder which is being dissected down, it will be easier to show on a video. Suppose the bladder is up till here, then what you do is you just push the bladder down after coagulating it at this level. The main problem is that the bladder pillar is a condensation of fascia which contains blood vessels, and if you just try to push it down without coagulating, you end up having bleeding. So that's all that you have to do. Again, it is there in the video which I have posted. You saw that there is a video on the shearer which I have posted, which is an unedited complete video. In that, bladder pillar dissection is explained very well. Previous CS, we all need practice, so don't worry about, nobody is very good. I am also still learning from many people. There are many more things to be learned as you go along. Uterine pedicles, occasionally I find some difficulty in lateralizing. So in lateralizing the uterine pedicles is the most important thing. Okay, lateralizing, the most important point to remember is how much to lateralize. Okay, so how much to lateralize? The answer of how much to lateralize lies entirely in the fact that you have to lateralize till you can do colpotomy. That's the simple answer. So if you are using a colpotomy tube, let's say you are using a Clomiphene or Professor Mangeshkar's manipulator, then you lateralize till the time that you feel you are able to circumferentially do a colpotomy properly. If you are using what I showed you, Dr. Sangpal's manipulator, and these are the, sorry about this, and this is the manipulator, these are the two side guards, this is the two arms, and these are the two diverging arms like I showed you, and these two, like we discussed in the webinar, these are going to be stretching out the vaginal fornices. So the cervix is going to be something like this, and the vaginal fornix is going to be something like this, and when you stretch it, you find that this is stretching the vaginal fornices at this level. So when you find that it is stretching, that means when you are able to appreciate the impression of the lateral border of the manipulator, that is where you are going to be performing colpotomy. So lateralize the uterine pedicles only up till that point and not any further. I hope that is clear. Then let's move on. Sorry about that. Problematic, uneventful, afraid of ureter injury. Here I traced ureters well near IP ligament but failed to dissect further near the uterine arteries. No, you cannot dissect near the uterine arteries because there is the concept of water under the bridge. The uterine arteries are crossing over the ureter. You cannot dissect this unless you are very good at your retroperitoneal dissection, and this dissection is required only either in CS cervix or while deroofing the ureter when the ureter is involved with endometriosis. So don't try to do it in the initial part of the learning curve. Overzealous, you don't try to do it as a routine, but this part of lateralizing the ureter near the uterine artery has to be done by deroofing the uterine artery, and you can see some videos on CS cervix to understand how that is exactly done. Otherwise this is not required. With adequate, try to understand that with adequate pushing of the bladder down, properly cutting of the posterior peritoneal fold, you are moving the entry point of the ureter away. So the bladder is moved away by your anterior dissection, the ureter is contained in the posterior leaf of broad ligament is moved away by your posterior dissection. So you will not, and with good traction, you will not be able to damage even if you want to damage. Okay, so dissection and traction is the key word here to prevent any sort of damage. So remember that traction is extremely important for safe surgery. Then we go to uterosacrals and vault. Vault post margin cannot be done. I did not understand. Vault cutting, how to get good traction. I showed you the vaginal tube. You can just push it inside and the traction will be. How to get traction while vault cutting. Demonstration of assistant giving traction. Just ask the assistant to push the vaginal tube inside. You will see the cup of the vagina. I have demonstrated it in the webinar video which I showed when we did the first case, that is bipolar scissor, TLH with bipolar and scissor. Opening vault, and thereafter I think you can see the video clearly. I have explained how to do. Many experts suggesting cutting uterosacral in the early part. I agree. I cut the uterosacrals in the early part of the surgery for the simple reason that it increases the mobility of the uterus. Okay, it increases the mobility of the uterus, and with more mobility I find it is easier to do surgery. But if you cut the uterosacral, then you have to remember to also suture them back, otherwise you will have vault prolapse. Okay, so this is very important. So but yes, I agree with cutting uterosacrals. I cut them along with the posterior peritoneum itself. and that gives me good mobility. This has also been demonstrated in our webinar video. Okay, so vault is a big headache, monopolar, left-sided bleeding at right side of vault after colpotomy. Yes, you have answered your question perfectly, doctor. Your problem is simply because of insufficient coagulation of uterine artery due to ipsilateral port from left side only. It's perfect answer. You have to coagulate from the other side, coagulate it well, and then cut off the uterine artery after the coagulation. Ligaments don't get the same strength. No, they get good strength. Over the past 15 years, touchwood, I have done many, must be 1,000 numbers of TLH, but I have not had one vault prolapse. So they get a good strength. Just reapproximate them with Vicryl. It should not be any problem. Then we come to salpingo-oophorectomy. I don't think anyone will have any issues over here. It's a pretty straightforward. But when I do this, after again I want to look ureter, difficult to see because of ureter, because of peritoneal cut, bleeding, or small hematoma or bulge. Correct. So after everything is done, if you want to look at the ureter, just ask your anesthetist to give a little bit of IV injection, furosemide IV, and that should take care of the problem. It should not be any trouble at all. Then coming to complications regarding recurring ureteric injury. So recurring, I would urge all of you, in the pre-course videos, I have put 3 videos saving the ureter 1, 2 and 3. These are extremely important because these are already there. I have not delved into them very deeply during the webinar, but I urge all of you to watch these 3 videos because these are very important. Venous bleeding near right uterosacral, exactly this problem and the proximity of ureter point we have covered in the webinar itself. LAVH safer to TLH when we no. So the point is that you have to dissect and lateralize adequately. Lateral spread from the cardinal ligament will happen no matter what you use, but it is a question of how well you have dissected the anterior and posterior folds away, which will lead to your not having complications. So LAVH more safer than TLH is a thing of the past. What to do when there is bleeding, discussed significantly. Port site infection, hernia, subacute obstruction, assistant closed port from outside. Yeah, this is a big topic. Maybe some other time we will take it. So this will require some understanding. Uterine artery, never tried that too much. Yes, but start trying little bit. At least try to open the peritoneum. Then try to open the areolar tissue. Okabayashi space, yes, you can do, but I would prefer lateral approach only. Few initial steps in, but able to reach water under the bridge, spot or uterine artery ligation. I have got 3 full-fledged videos on uterine artery ligation, maybe more. In fact, in the pre-course only there are 4 or 5 videos. Those should be enough to tell you how to do this. Show sigmoid dissection and approaches for ureter tracing. Again, showed already in the first case in the webinar itself how to do sigmoid dissection and how much to do, and lifting the sigmoid and pulling it down and cutting it from the top. So just as a recap, don't be too worried about sigmoid dissection. So for example, if this is I am operating on the left side, this is the left lateral pelvic wall, and this is the sigmoid over here, then you find that there is sigmoid. After the sigmoid, there is always going to be some fat. Okay, after the fat, there is always going to be some peritoneum, and then comes the lateral pelvic wall. So when you cauterize or when you cut, be sure that you are cutting at the level of, I'm sorry, I erased that. So be sure that you are cutting between the fat and the peritoneal wall. Some amount of current going to the fat is not going to do any harm. But this is the most important thing here is traction by the assistant. If the assistant does not give traction, you will not see where you are supposed to go. Usually dissect the ureter. I find it difficult. Ureter is very deep down, often bleeding when I get deeper. Any recommendation? My senior taught me not to cut the round ligament, so uterus will be supported, reduce need for manipulation. You can. Personally, I don't see any much role of cutting or not cutting the round ligament unless it is a conservative surgery. I usually tend to cut the round ligament because I get better exposure. And for the bleeding part, what I would recommend is, once the 2 folds of peritoneum are open, there are fibers which run between the folds. So if you see this, for example, if this is the lateral pelvic wall, external iliac artery and external iliac vein, and here you have got one fold of peritoneum which you have cut and the other fold of peritoneum which you have cut, and you expect the ureter to be in this peritoneal fold. What you find is that over here you have got areolar tissue, but it is there in the form of fibers, and these fibers contain blood vessels. So rather than bluntly dissecting them, if you cauterize and cut them one by one, then you find that it does not lead to any bleeding. Follow the ureter and stay parallel and lateral to the ureter. So parallel and lateral to the ureter, and by you are sure to reach the uterine artery after some practice. So I think that is done. Finding difficult, never done. I'm sure after some practice all of us will be able to do. Morcellator specimen vaginally if uterus is bocellated. I already showed you, if the uterus has got multiple fibroids, then each fibroid has to be cored either in the center or by lateral coring, how I showed, and then it has to be removed. Don't try to do it very fast. Exclusive lecture for suturing. Yes, like I said, suturing requires hands-on and it requires physical event. So maybe I don't know when I can plan. We'll try to do that. Monopolar current I don't use frequently. There is no harm in using monopolar current. It is not a bad form of energy. People say that it is outdated. There is no such thing like that. I don't use monopolar current because I find it easier to do start to finish with one energy source only. But you can use monopolar current, there is no problem. Like I said, there is a difference between monopolar cut and monopolar coag. So wherever possible, use monopolar cut, don't use monopolar coag, and there will be very minimal lateral spread. But whenever you are using monopolar, of course, needless to say, you must keep the bipolar handy. Okay, so any comments on gasless? No, I have not done a single case in my life with gasless laparoscopy, so I have no experience. Basics of suturing again requires live session. How to give traction by assistant, as how assistant to know. I'll have to make a separate video of traction. You will have to correlate what you see on the recorded video and try to give that same traction vaginally and try to emulate that same step. How do you manage with cervical fibroid? Videos are there on the YouTube channel. You just have to look up to the channel, subscribe, and you will find 3-4 good videos. Endo suturing, morcellator, obese patient in Hong Kong, there is an anti-slip mat, cost on wood. So what we do is, first of all, we put a bolster under the patient's buttocks like I showed you, and because of this bolster you find that there is requirement of Trendelenburg position is a little reduced. Anesthetists are also happy, patient also doesn't slip, but you sometimes have shoulder guards available. So these shoulder guards, these are like large shoulder pads, and they go above the patient's shoulders and prevent the patient from shifting down. Maybe an orthopedic colleague will be able to tell you they use these extensively. DIE is a big topic, cannot really delve into it anymore on a TLH session. Cleaning of instruments is too basic. Maybe sometime we'll have another, I'll post a video on the topic. Did TLH today? Same question. I think we already answered that. So I think those were the questions till now. I encourage all of you to keep sharing your experiences in the group and helping out each other. For those who have not yet joined, again I would urge you, please visit our website www.endogynetraining.com, and there you will find the link to join our common WhatsApp group where we keep posting daily life questions and dilemmas related to gynae endoscopy. So please be sure to join the group, and you can also receive our updates as we keep posting them. Also, I keep posting updates of training programs, etc. on this group. So that's it for now. I think keep the .com TLH group alive by asking more questions and by helping out each other whenever it is required. I'll try to answer your queries as and when and as frequently as I can. So thank you very much.